I'm going to talk to you guys today about the surgical therapies in Parkinson's disease. I always like to start with the disclaimers and disclosures, and it's easy because I have really no disclosures. I'm not involved in any drug companies or any of these DBS devices by any means, but I am an avid Googler. So a lot of the images today are either things that I've created, things that I've had or seen with patients, specifically videos, and then of course taken from the internet, which is home to some of the best figures for this talk. The plan of attack today is going to be, and really hit on 3 parts. The first is just really going over some of those basics, kind of talking about and picking up where Dr. Jakowiak left off with the review of the fundamentals of Parkinson's disease therapy, with hopes of then going in and answering 2 big questions. The first question is, should I be considering surgical therapy? And also, when should you be considering surgical therapy? And then which surgical therapy is right for me? Because there are options as far as the surgical therapies for Parkinson's disease go. So when you hear, and when we as physicians hear about that typical appearance of Parkinson's disease, this is a great slide or figure that I always pull up and use in talks because it highlights some of the main things that either you yourself as a person with Parkinson's disease, or more often your spouse or loved one, friends, family, coworkers, and say, well, you're starting to have a little bit of that stooped in your posture, or may hear that shuffling when you walk, or see a little bit of that tremor. And those symptoms in itself, as well as what Dr. Jakowiak went over in his talk, are when we start having that conversation, or brought to your doctor about, all right, are these symptoms Parkinson's disease? And after that talk and after that diagnosis, that initial diagnosis of Parkinson's disease, the next thing that often comes up was, well, what are we going to do about it? Okay, what can we do for these symptoms, especially those cardinal or main symptoms of Parkinson's disease, like that tremor or the slowness or the stiffness? And that's where this brain chemical comes in, this neurochemical comes in of dopamine, which we talked a little bit about with Dr. Jakowiak's talk, and is the main chemical, the main brain chemical implicated in causing those symptoms of Parkinson's disease. And over many years now, we have a number, more than 2 handfuls of medications in our arsenal to replace or mimic or act like that dopamine in the brain. Things like your carbidopa, levodopa, or Sinemet, in any different form that we have of it. Immediate release, controlled release, Rytari. Or the Ropinirole or Requip, as one person mentioned, or Pramipexole, Mirapex. The list goes on and on as far as the number of medications we have in our arsenal to tackle, especially those main symptoms of the disease, the tremor, slowness, and stiffness. And this can be great. Okay? If you reach that point and if you have symptoms that say, this is bothersome to me, okay, I would like to try one of these dopamine medications, especially early in those first number of years in Parkinson's disease. We can try these medications, and our response to those medications can be fantastic. With taking a pill, taking a medication, and it lasting a good 4 to 6 hours, okay? Finding itself right in that good window where you're not going too high on it, you're not too low on it, and you have a really good effect. And you can continue living a really great and wonderful life, even with the diagnosis of Parkinson's disease. But as the disease progresses, some, not all, but some patients with Parkinson's disease can advance with the need for the medication, whether that be needing more medication, which is a consequence of the brain just wanting and needing more dopamine. Not that you get used to it, your brain just needs more as this disease progresses. You may also find yourself taking the medication more frequently, okay, where we often start twice or 3 times a day taking the medication. There are persons with Parkinson's disease who their brain is telling them that they need this medication every 4, 3, or even 2 hours. And that's pretty frequently. So we can find ourselves in a position, as the doctor in persons with Parkinson's disease, where that window, that nice, what we call therapeutic window, where you hit it, you're feeling good, the tremor, the slowness, the stiffness, and any other symptoms that respond to that dopamine medication, okay, it's hard and hard to get in that window. Many times, or at times, we can go above and beyond, kind of knocking at the ceiling or going above that ceiling, where we can experience those dyskinesias, those extra movements, that dance, not a good-looking dance, but that dance with Parkinson's disease. or we just are not there. We're not getting above the floor. We're actually starting to get a good effect, or it drops out too quickly. And so the main symptoms that are really complications of Parkinson's disease, especially long-standing or durable Parkinson's disease, many a times a combination of not just having the disease but also medications, are those dyskinesias, the motor fluctuations, or the ups and downs throughout the course of the day, going up and down in or around that nice therapeutic window of feeling good. Sudden offs, which is when the floor just falls out from under you for no good reason. Okay? And so that's another complication of Parkinson's disease. Or dystonia. And that's cramping or turning or twisting or posturing of a limb, usually the toes, the foot, sometimes the arm, or even the neck. So in short, these Parkinson's disease symptoms can really be like a roller coaster. The ups and downs, trying to catch up, trying to anticipate that next downhill or that loop or that corkscrew. So the first thing I always like to tell, and this is just how I practice, is I think it's of utmost importance to start that conversation about surgical or advanced therapies in Parkinson's disease when you and your doctor are starting to know that we're approaching that hill of that roller coaster. We're starting to go up that hill, and that this roller coaster ride may be something that we may very well be coming up to. But there are, and outside of just that feeling, okay, that, all right, well, I'm forecasting as the person with Parkinson's or the doctor, we might be running into a tough spot with the disease as it advances. There is a check mark. There are check mark boxes which allow us to fall back on. The first check mark box when to consider surgical therapies for Parkinson's disease is that, first and foremost, for surgery for Parkinson's disease, you have to have Parkinson's disease. We want to be assured of that as the doctors, as the surgical team, when we're considering surgery for Parkinson's disease. In part, as Dr. Kowiak said, is that I like to think I'm pretty good at being and diagnosing Parkinson's disease as a Parkinson's specialist, but am I perfect? No. And as we know, about 80%, a little bit over 80%, especially earlier in the disease, is how accurate we are at making that diagnosis. So we like to wait, and these numbers are arbitrary or out there, but we do like to wait 3, 5, or more years after the diagnosis of Parkinson's disease so we can be sure or certain that this is the disease that we're working with before considering surgeries. I often tell patients that I made a diagnosis today of Parkinson's, but I did not bring my drill into work, okay? So don't worry. The other thing we like to see is that we want to see that you've had a good response to the dopamine therapies, because most, 2 of the 3 surgical therapies that I'm going to talk about today, they can give you at or more likely near the same benefit of the dopamine medications compared to the medications. Not often beyond, but at or near your best response to the medications. So we want to see this, and you'll often be evaluated for surgical therapies in your best on and your worst off state. And then the nitty-gritty and the largest checkmark box of them all is whether you're having any of those motor complications or advanced complications of the disease. And this includes the dyskinesias. Not just having them, but those dyskinesias being bothersome to you, getting in the way of life, being socially embarrassing, dyskinesias being bothersome. Those motor fluctuations, the ups and downs, and just having a hard time steadying that ship. Those sudden offs where it just drops out. Okay. The medication refractory tremor, or as I may mention, the stubborn tremor sometimes that we see in Parkinson's disease, where it doesn't matter how much dopamine or what types of medication we're on, we just can't get quite an adequate control of that tremor. Or if we're limited, we're trying these medications and trying any number of the medications that we have for Parkinson's symptoms, we're just limited by the side effects of the medication, which we can run into at certain doses or in certain persons. So when you take this category, when you take this last category checkmark box, at large, we start thinking of time to consider the surgical therapies broadly in Parkinson's disease when the medications that your doctors have fail to smooth things out, okay, and give you that quality of life from those symptoms that you want and need. So while there are these nice checkmark boxes of things to consider or when to consider surgical therapy for Parkinson's disease, things that we really do want to have, there prior to considering it. There are also things that can bar you or make you less desirable of a candidate for these surgical therapies. The first is, of course, in really countering the first checkmark box on getting surgery, is that a diagnosis other than Parkinson's disease, like some of these Parkinson's plus or atypical Parkinson's diseases, it may very well be an exclusion from having that surgery. The benefits just may not be as worthwhile as if you had run-of-the-mill Parkinson's disease. Having significant memory problems or dementia may very well be one thing that bars you from surgical therapies, because it takes a lot of work to undergo the surgery and a lot of teamwork between you and your doctor, which problems with memory can interfere with. And on a similar stance, significant problems with mood or anxiety or psychosis or otherwise hallucinations could be something which might make your team a little more timid to pursue the surgery. Again, knowing that it's something that it really takes a lot of work and interaction and good communication to level out. But if you check the boxes, for when is it time to consider surgery, and you don't have any of these boxes of when you would be barred or excluded or a less favorable candidate for surgery, that's when we break out the big guns. So the surgical therapies for Parkinson's disease are 3, and we'll talk about all 3 today. First one we'll talk about is the Duopa Pump. Second, we'll talk about DBS, or deep brain stimulation surgery, which is the one that's been around the longest of all these 3, and the one that is probably most frequently used. We'll spend a good amount of time on that today. And then this last one, which is Focused Ultrasound. It's really the new kid on the block as far as surgical therapies for Parkinson's disease go. We'll spend a little bit of time on it, but bring it into the conversation today. So the first surgical therapy in Parkinson's disease that I wanted to talk about today is that Duopa Pump. So what is this Duopa Pump that we're talking about? So the Duopa Pump comes off the tongue a lot better than carbidopa-levodopa intestinal gel. Okay? And so that's why we say Duopa Pump. But carbidopa-levodopa, a lot of you have heard that. A lot of you heard that term, and carbidopa-levodopa is just Sinemet. It's the mainstay. It's one of the main medications we use for Parkinson's disease. So what the Duopa Pump is actually is just a different method, a different delivery system to get that Sinemet, okay, that many are taking in pill form, to where it can be absorbed so it can get to the brain. So carbidopa-levodopa intestinal gel. Now this system is delivered through, and it's intestinal gel, so it's delivered through a device, actually a little cartridge or machine, and that intestinal gel is pushed through a feeding tube, okay, or a tube that goes from the outside into the stomach and just below the stomach where that medication can be absorbed. Now, this question comes up, and this is an important question. Who is Duopa? Who is carbidopa-levodopa intestinal gel? And who's it for? Well, first and foremost, it's for patients who still have a good response to the dopamine medication, because that's all this is dopamine, carbidopa-levodopa or Sinemet in gel form, but who have maybe a narrow therapeutic window, meaning that they're up and down, and it's hard to pinpoint. And by the way we take pills, it's hard to get right in that therapeutic window, leading to motor fluctuations. If you have too frequent dosing, okay, most people can't take a Tic Tac every 2 to 3 hours, let alone a medication or a pill for Parkinson's disease. And so if the dosing is just too frequent for your lifestyle, okay, for you to continue to live in a good life or lifestyle with Parkinson's disease, that's another indication, another reason to consider something like Duopa. Or if there's trouble taking pills, okay, if you have a good response to the medication, but you just have difficulty taking the pills, maybe due to problems swallowing or otherwise, that's another reason or indication to start thinking about something like the Duopa Pump. So what this is doing, and I put together this graph, the Duopa Pump is taking what we experience from the pills form of carbidopa-levodopa or Sinemet, where it pops in and out of the system depending on when we take the medication and how much. The hope or goal of the Duopa system with that intestinal gel is that it just balances that out, keeps us in that therapeutic window where you're not too high, not too low, and really knocking things down like the motor fluctuations. Now, the ins and outs of the Duopa pump are that it's a pretty continuous infusion. I say pretty continuous because in most folks and most persons with Parkinson's, the continuous infusion is run for 16 hours of the day, with many just pausing it at night and not needing necessarily the medication during that time. So about 16 hours of continuous infusion with how fast that medication's infused, adjusted or titrated by your doctor. Even though this is a continuous infusion of that medication, there's still an allowance for extra doses, or PRNs, when you're in a pinch. Okay, when you really need that extra jump in the tremor, slowness, and stiffness, where you feel like it's wearing off, depending on what you ate, or the time of day, or what you're going out to get into. Okay, you can still use and actually give yourself an extra bolus or jump start with that medication through that system. And even though administering the carbidopa-levodopa intestinal gel, or Duopa, goes through a pump and a tube, okay, continuously, it doesn't mean that you can't still eat, drink, take pills, be merry, and do all this. You can still take pills on top of the carbidopa-levodopa intestinal gel, on top of the Duopa pump. You can still eat, you can still drink. This is just, again, a different mechanism or a different method of delivery of that medication, so you don't have to pay as much mind or attention to it. Now, with this, and because this is a device that's external and it's there, it's attached to you, we have to do a couple things when we manage Duopa pump. I mean, first and foremost, it does have to be on a daily basis maintained. And this intestinal gel, this Duopa gel or carbidopa-levodopa gel, comes in these cassettes, these little cartridges that are often refrigerated, and you have to change those out daily. And sometimes even more than one cartridge daily, depending on your symptoms and how much you need. And you can't reuse them. You can't rewash them, put some more carbidopa-levodopa intestinal gel in there, and get right back on the saddle. These are things that you have to replace each time it's empty or you need it. The Duopa pump, of course, works through a feeding tube or a tube going into the stomach, and so you do, because of having that tube going from the outside in, it does require general tube care. So you have to be able, either yourself or have somebody there, a nurse, a loved one, be able to do that general tube care, the cleaning of it, the flushing of that tube daily to make sure it doesn't get clogged or dirty or cause or put you at risk for things like an infection. And then it is recommended that you take this off before swimming or submerging in water. Or when I trained in Florida, a lot of people had horses. So riding a horse, probably don't want to have this cartridge, this device, hanging on your side. And at the end of the day, though, this Duopa pump, the carbidopa-levodopa intestinal gel, is still dopamine. Okay? It's still dopamine at the heart of it. So the side effects of dopamine are still quite possible. Things like getting tired. Okay, or it having an effect on your blood pressure or causing a drop in blood pressure or whatever it be. If you had side effects to the Sinemet that aren't just ups and downs of the medication, these are still side effects you can continue to have even with this delivery system. One of the most important parts of this, again, is that this is an external wearable device. Okay, and it's not small. It's a decent-sized device that you usually have to have some sort of purse or carrying case for it. And they've come out with a lot of different, fairly stylish cases for this, whether it be a vest, a chest pack, a crossbody pack, or my favorite, or what I know patients utilizing most, is actually just some sort of stylish purse or fanny pack, okay, as being the way to hold this, which conceals it quite well. You just get a lot of comments on your nice-looking fanny pack. So we actually don't do yet the Duopa procedure or administer Duopa here at the University of Michigan. That may very well be something in the future that we entertain, but it is, again, the Duopa pump is a good consideration for the right person as an advanced therapy for Parkinson's disease. Now I'm going to switch gears and not talk about Duopa or this Duopa pump, but talk about really of the surgical therapies, the one that's been around for the longest. And that's going to be the deep brain stimulation, or I'll refer to it just as DBS surgery. The first thing, I don't know if it's a myth I want to dispel or debunk, but not everybody who has DBS surgery has that big of a smile on their face. There are many who do, but not everybody. So DBS surgery, what this really is, for lack of better terms, it's a surgery where a wire, sometimes one, sometimes two wires, are inserted deep inside the brain to a specific spot of the brain that can assist or help with certain symptoms of Parkinson's, which I'll discuss. It's completely under the skin. Okay, when all is said and done, this is fairly invisible to you, invisible to others, procedure where you have this tunneling all the way under, from the top of the head, behind the ear usually, around the neck, and under the skin in the chest, where there's a nice little pocket for it to be worn. And this DBS, what it does is it provides a constant current, a constant electrical stimulation to these spots to relieve select symptoms. Now, where this DBS is placed, okay, outside of simply just deep into the brain, really depends on the symptoms that you're experiencing and the experience of your DBS team, okay? And I won't go into it too deeply, but these structures that the surgeon is targeting to put this very tiny wire in, well, one of these structures is about the size of a lima bean, the other one is about the size of a smushed pea. Okay, we're getting lunches after this, so I figured I'd use a food analogy. So how does it work, though? The short answer to that is that we don't know. We don't know exactly or precisely how DBS works, but we like to think that by putting giving this electrical stimulation into these very specific parts of the brain, that we can calm down, silence, or turn the volume down on the abnormal signal generated from these deeper structures in the brain, and let the surface of the brain work like it otherwise would pretty normally. The other way to think about the DBS is probably not so much of how it works, but what it looks like or appears like. It's really serving as a pacemaker for the brain. And that's not a bad way to think about the device itself, especially with its appearance, but it's probably not keeping a pace for the brain. Okay, it's not like we can turn it up and you'll just be going even quicker, okay? Superhuman movements, but rather it's really more designed about how it looks, a pacemaker for the brain. And that is not far-fetched, as this device with a battery pack, or what is actually delivering or causing the stimulation being under the chest wall, under the skin of the chest at that, connected to a wire that was run up, and then with electrodes going deeper into the brain, into those structures. And this device, while it may sound scary that you're going to have, or you have something under the chest, is not that big. It's not that big, and many folks, not very noticeable after the surgery is healed and performed. So what can DBS help, or what can DBS do for you with Parkinson's disease? And I have the list of symptoms that often respond to DBS. And that's that bradykinesia, or slowness in movements. I always joke with patients that at home, okay, you don't sit there and do this tapping, but that, typing at a computer, buttoning buttons, all these things are things that can improve that slowness with DBS, and often does. That stiffness or rigidity is something that can improve, and often does. Tremor, even that stubborn tremor, even that stubborn or medication refractory tremor tends to improve with DBS. As do some of these extra movements, the dystonia, or that cramping, or dyskinesia, that up and down, that dance-like movement, are symptoms that typically respond to DBS. And because the electrical stimulation or current from the DBS is really 24 hours a day, in most cases being administered, it can increase your total on time. Whereas the medication can go up and down in the system, and is often still used. Medication is often still used simultaneous at the same time as the DBS. Your total on time, okay, throughout the day is usually improved significantly by having the DBS stimulation on. And in that same manner of thinking, the motor fluctuations, the ups and downs, can be leveled out with the DBS. Now, while those are the symptoms that often do improve with DBS, there are symptoms also that may be improved with DBS. Most of these symptoms that can or may improve with DBS, I should say, are often seen to improve if you have a good response to these symptoms with your carbidopa, levodopa, or dopamine medications. Things like camptocormia, which is a bending of the posture forward. Things like Pisa syndrome, which is leaning to the side. Fatigue, restlessness, depression, freezing of gait, or getting stuck with when you're walking. These are symptoms that often improve if you have an improvement of those same symptoms with the dopamine medications that you're taking, then we can see those with the DBS. If not, especially freezing of gait or walking difficulties, if it's not responding to the medications, it may very well not respond to the DBS. It's a really important thing to know. And then, of course, there are symptoms that DBS won't help. Okay? Because DBS in total, it doesn't stop or slow the disease, it just treats a lot of those symptoms that I just discussed. As you can imagine, DBS is not going to help things like autonomic dysfunction. DBS probably is not going to help constipation, okay? Or getting lightheaded or dizzy, or urination. It probably is not going to help those symptoms. It probably does not help things like any difficulties with swallowing or speech, or at least only does so minimally. And it doesn't make you smarter, okay? DBS is not going to make you the next Jeopardy champion. And a really important one is that DBS doesn't help that postural instability or that problem with balance and falls that we see with Parkinson's disease. Can it make you walk quicker? Yes. Can it make you a little quicker on that step to correct yourself? Yes. But a common misconception with DBS is that it's going to help my walking. And that's just one thing we just don't see quite the benefits, even though we would like and to keep trying to find and get that and fine-tune the benefits for that. It's just one thing that we just don't quite see a robust benefit from. So there's another reason why I always encourage folks to start the conversation about these surgical therapies before we get into the twists and turns and the roller coaster ride that some folks experience with Parkinson's disease. And that's because DBS, the time for when you tell your doctor that I want to consider DBS or I'd like to do the surgery, can take time. It's a process. With the first step in this process often being that you meet with really a whole DBS team, okay? A whole DBS team to say if DBS is right or not for you and how to proceed. That PD surgical team or DBS surgical team in the University of Michigan is composed of folks like Dr. Wyatt, Dr. Chu in the background from the neurology side of things. Dr. Parag Patil is the lead or most common neurosurgeon here who does the surgery. Laura Zeitlin. So if it takes a village to go through the DBS candidate evaluation, Laura's probably the mayor of that village, really orchestrating it and probably having some pretty common communication with you. Or as a parent of 2 young boys, in maybe about 30 years, we might get them as part of the DBS team. So the DBS evaluation, after you undergo and after you meet that team and they put you through different testing, also maybe evaluating your speech, your swallow, your memory, your thinking, all to say, all right, is DBS going to be the right thing for you and how should we go about it? Then you talk, and if you get that passing grade, you go and talk about scheduling the implantation of the leads, which the surgery itself for implanting DBS takes about 1 to 2 days of a hospitalization. Okay, just 1 to 2 days to put in the leads, but then about a couple weeks or a few weeks or a month later, you often have to go back and then get those wires that you had implanted connected to that battery pack with that battery pack installed. So that takes place usually a couple weeks or a month after the initial surgery in most cases. Once that's healed or about a week later, you go back and you get that DBS turned on and you have that initial programming, which can often start to see benefit with some fine-tuning of that program, some fine-tuning of that programming, getting things set over the following 3 to 6 months. In short, this is a process. This is a pretty long process that often can take a year or more from when you first make that decision, say, doctor, I'm ready to talk about DBS, I'm ready to do it. Again, I don't bring a drill to work, so once you make that step in that process, it can take some time. And this is another video I wanted to show of what DBS could look like. I'm teaching these folks young on a plastic brain mold. Yeah. And there's 2 of them. So I have some work to do yet. They're not quite yet skilled enough to do this surgery, but I have plenty of years to work at them. So what does DBS surgery actually look like? It's not nearly that fun. Okay, it's not nearly that fun as my kids playing with a plastic brain mold. DBS surgery more often looks like this. Okay, and this is a common image of DBS surgery, one that I took from National Geographic, which is on my first day of movement disorder and DBS fellowship. National Geographic happened to be in the operating room with a bunch of folks filming for this segment that was featured a couple years back. And so this picture right here of a patient with Parkinson's disease connected, and you'll see that he has this apparatus, all this stuff around his head. It's not uncommon to have this apparatus around your head to keep your head in place. Okay? So you can't, while the surgeon is putting in this DBS lead, so you can't sneeze, okay? Or have a tremor or something that says, oops, I missed, I'm in the wrong spot now. You have a rigid head frame often that's, for lack of better terms, bolted, right? Bolted or firmly secured to the cranium, to the skull, so that everything can be working in precise fashion, and a sneeze so it decreases any oops moments that could happen from the surgery. And as you see here, this patient is awake. Okay, he's awake. This is not uncommon to have this surgery in the awake state where you can talk and communicate with your DBS team about how it's going, are your symptoms improving or not. It's not uncommon. So this could be a really intense experience for somebody to undergo a surgery like DBS. And there are variables. Okay? How we do DBS surgery here at the University of Michigan could be different. All right? It could be different. Probably not in many ways, but in some ways compared to Cleveland Clinic or Mayo or whatever hospital you would have DBS at. Those variables include being awake or asleep. Historically, folks were awake during the DBS surgery so we can gather information about their symptoms as we're doing the surgery. But now, we do a lot of surgeries actually in the asleep, while you're asleep as well, so you don't hear, say for instance, that drilling of that small dime-sized hole in the skull, which sounds like a bad experience to a dental office. So you don't hear that, because that can definitely be alarming. Sometimes we use imaging or MRI, especially for those sleep surgeries, to find the right spot in the brain. And sometimes we use a combination of imaging, pictures of the brain or MRIs of the brain before you undergo surgery, plus listening to the sounds, which are the sounds are just generated from the electrical currents in the brain to help us pinpoint exactly where to put these wires. Some folks do one side, some folks do two sides, and sometimes those sides are even done on the same day, or they could be split months apart. And then in total, while it's a variable, most folks with DBS probably spend a total of just 1 to 2 days, 1 to 2 days or 1 to 2 nights in the hospital. This is a pretty quick procedure. 3 to 6 hour surgery in total for the implantation of the leads, a stay in the hospital, and then coming back for the implantation of the device under the chest wall. So what are the risks? And these are important to know. What are the risks of DBS or deep brain stimulation surgery? Well, the first thing I say, unlike Duopa is not a brain surgery. There's risk, of course, associated with putting it in a tube and maintaining that, but DBS is a brain surgery. So the risks, things like stroke, having a bleed of the brain, an infection, a malfunction or twisting or breakage, or having to replace hardware, those wires and that process, that is a real surgical risk. In total, probably 5% or less. Many of these risks being around 1 to 2%, so 1 to 2 persons in 100. And in total of all these risks, about 1%, so 1 in 100, about 1% of folks who undergo a DBS surgery could have a significant long-term complication. This is definitely something to consider. When we do 50+ cases a year, once every 2 years, we may have a patient who has a significant long-term complication. And then not only are there the risks of the DBS device itself, but there are risks of the stimulation provided by the DBS. And it doesn't shock your brain, it doesn't fry your brain, it doesn't do anything of that nature, but if you stimulate just outside of that lima bean, or just outside of that smushed pea area of the brain, which is millimeters, we know we can cause problems by the stimulation alone in things like balance, or swallowing, or speech, or even thinking, okay? So in a big nutshell, that is DBS, or DBS stimulation for Parkinson's disease. I'm going to spend just a few moments to talk about focused ultrasound, which again is the new kid on the block. So focused ultrasound is really exactly as it sounds, okay, where for Parkinson's disease, and when it's used, what they do is with a contraption that shoots a lot of different ultrasound beams to a very particular part of the brain, is worn to really isolate the same or similar spots we use in Parkinson's disease or tremor suppression surgery. And in doing this, in focusing all these beams of ultrasound, okay, without drilling any holes, without making any cuts, we can essentially heat up, okay, or turn the volume up or heat up the parts of the brain that are causing some of these symptoms or that can give improvement. And by heating it up, for lack of better terms, we burn or cause a small lesion in those parts of the brain which can calm down or quell those symptoms. Now there's a lot, and focused ultrasound is fairly new. It's only been out there for about 3 years for another condition, not Parkinson's disease or not directly linked to it, but essential tremor. So far, as far as I know, the focused ultrasound, or FUS therapy, for Parkinson's disease is only approved for when you have that medication refractory or stubborn tremor. You can only safely do, because you're creating and you're burning a hole in the brain, and we can't unburn a hole in the brain. You can only safely do one side, because burning or causing a lesion on both sides of the brain definitely increases the risk of side effects from it. And your significant other may very well joke with you on this matter, but you can't have a thick skull. Okay, there are actually very specific skull characteristics that you have to have when having this. So I always love that one. And then because this is permanent or irreversible, unlike DBS where you can stop stimulating or take it out, this is something that if you do suffer side effects from the focused ultrasound surgery itself, there may be side effects that you may very well have to live with going forward. And in total, it's still infrequently performed. The list of centers doing focused ultrasound for essential tremor or Parkinson's disease tremor is expanding. And in our region and around us, we have places like the Mayo Clinic and Cleveland Clinic doing this, as well as Ohio State, so some small institutions, but it's still infrequently performed. So the skill set of the surgeons, of the folks operating to this regard, is still fairly minimal. So surgical therapies in Parkinson's disease are really numbered 3 right now. The Duopa pump that we talked about, which just administers that carbidopa-levodopa, or the Cinemet, through a different delivery system. The DBS, or deep brain stimulation surgery, which via a wire and things channeled under the skin, invisible to the naked eye, gives electrical current to help and improve certain or select symptoms in Parkinson's disease. And focused ultrasound, which again, new kid on the block, essentially burning or causing a small scar or lesion in the brain for Parkinson's disease for medication refractory tremor. The key points, and if there's 3 things I want you to take home today, it's not that your significant other may or may not have a thick skull. It's 1, start the conversation earlier rather than later. Okay, start the conversation about DBS when you or your doctor feel that you're approaching that roller coaster ride, so it really sets you up for success and really minimizes the downtime that you have or the troublesome times you may have with this disease. Know that you have options. Okay, DBS, while it's the most common surgery done, is not the only surgical option out there for Parkinson's disease, as we reviewed today, and there's no one-size-fits-all. Surgery may not be right for you. Surgery, DBS, or Duopa may be. Okay? There's no right one-size-fits-all, and the reasons you choose one versus the other are totally person-dependent. And of most importance here is that you want to make sure that you're aligning your expectations, what you gather from this surgery with the risks and benefits of it, Duopa, focused ultrasound, DBS, or otherwise, that the expectations of what you're going to get out of it are really worth the risks of the surgery, of having the surgery done. Very important. In total, so you can really continue to be the supermen and women that you all are, living with this disease of Parkinson's disease. So I want to say thanks for having me, especially thanks for having me give this talk this year, and happy to entertain any number of questions until time runs out.